Well, welcome to the latest session of the scapular video series. This is going to be an interesting session right here. What we've done here is we've created a model of the scapula, the scapulohumeral rhythm, and the normal kinematics and abnormal kinematics of the scapula. And hopefully we'll be able to illustrate these points to you all so you can help both in evaluation and also in interventions and treatments. As you can see, it's kind of complex here. We have modeled the scapula. We have modeled the spine, the sternum, the rib cage, the arm motion, so we can vary the positions. We've also modeled most of the muscles that go around the scapula to function as scapular movers and controllers. And so as you can see, it's quite complex. You see it takes a lot of muscles. And as we are pulling on this, you see it takes a lot of people to make this happen. So hopefully we can illustrate these points both in normal function and in several of the abnormal functions that we normally see. So we've assembled our group here. So we're going to tell, each of them are going to tell you what muscles they are working on and how we're going to work on. So we've got Austin Stone from the University of Kentucky. So what are you going to do?
Well, I'll be the deltoid and also be the arm movement.
Okay, you got Tim Uhl from the University of Kentucky, my mentor. What are you going to be doing?
So I'm going to be focusing on lower trap, middle trap, and upper trap activation.
Okay, my practice colleague, Dr. Jeff Grantham at the Lexington Clinic.
I'll be acting as the levator, the rhomboids, and then the pec minor.
And then my colleague, Aaron Shasha.
I'll be doing the superior and inferior aspects of the serratus anterior.
So we've got a lot of muscles going on here all at the same time. So we'll start off with, let's understand a little bit about what the muscles actually do, more or less individually, but we'll also show how it works together. Now, we've always considered that the serratus is one of the key muscles. It has two components here, an inferior component and a superior component, both of which really go to stabilize the scapula, especially in the first stage of scapular motion, where it actually has to set itself against the rib cage to allow a base for further motion. So Aaron shows, just look at the activation of the lower portion of the serratus. And you see how it pulls down and really locks that inferior medial border right down where it's supposed to be.
On that side. Yep.
And then the upper part is more of a rotational going up this way right there. So those are the key actions of the serratus function. Now, Tim, I've always been a big low trap guy. So what's the low trap seem to do here?
So the lower trap is one arm. By itself, it's sort of inferiorly gliding the scapula. But when you put it in concert with the upper trap, you'll start to see a little rotation. And my buddy Aaron's keeping a little tension. We really get excessive upward rotation in that with all three components working.
So if you now just tighten up the lower trap, I mean the lower part of the serratus. Now do your two trap muscles right there. And that's more of a coordinated pattern. Is that correct? So
yeah,
it takes,
so you're getting upward rotation and posterior tilt and a little bit of external rotation. Our deltoid is quiet right now, but that's okay. So you can see that scapular motion.
One other point about this low trap I think is missed a lot is that as it works, it's an external rotator of the scapula, but also is a posterior rotator of the clavicle. And this posterior rotation of the clavicle is the primary motion of the clavicle in arm elevation. So Tim, show them, if you can look at the clavicle, how it posteriorly rotates and retracts. Very important function of the low trap in part of this whole scapulohumeral rhythm. Now, in general, Jeff, you get the muscles that are in our way. So show us a little bit about the levator here and how it tends to want to be tight all the time, and it'll pull up. And that's that shrug we're talking about. And of course, our friend, the pec minor, it basically pulls it around, protracts it, and that's one of the major problems we all see with the arm down to the side. It just gets in the way. Now, so that's the norm. Now, and then Austin, the deltoid is a very important muscle in terms of elevation of the arm. So you can see how the deltoid and arm load actually put a huge amount of eccentric force on the medial border, and it has to be opposed by several of the muscles. We're going to show that here in just a minute. So you guys, what else do you want to show here about the normality of this? Anything? Oh, the other thing is this clavicle has to work as a strut. It has to be attached. If it's not attached, you don't have a clavicle. You got no normal motion. So now we're going to try to put all these together in a way that shows this normal scapulohumeral rhythm. So now also I want you to just kind of, basically you be the arm now more than, and just very gently hold that right there. So now let's work together to make this work as a unit. So that's what we want to see. This normal upward rotation, external rotation, and posterior tilt to put the glenoid in the normal position so that the arm can now work where it's supposed to work. Without that, then the arm cannot move. So for example, let that go.
So can you pull your serratus just around the curve? There you go, because that would be more how it would actually
Yeah,
function.
as it comes up, there's where now you're getting into the position where the arm and the glenoid are lined up in the way. And it takes the scapular motion to put the glenoid in the right position so that now the arm can articulate off of the glenoid to do the normal functional activities in the overhead position. Without this motion, you cannot get the stability of the glenohumeral joint, which allows for normal concavity compression, normal ball and socket kinematics, and normal function of the arm in the overhead position. So if you don't have a scapula, you don't have a good arm. So do that again, just show the normal kinematics here that takes. That's good. And even though we talked badly about the pectoralis minor, it still needs to work there to help hold that down in position as the scapula rotates. There's the force couple. So Tim, tell us, what are the force couples that are working here?
So there's two force couples. One is the rotator cuff, which is basically the deltoid and all the rotator cuff muscles. This is sort of representing the infraspinatus. We have a displaced deltoid. There we go. So that's the rotator. The force couple at the rotator cuff is probably what most of the literature focuses on. And then the scapulothoracic force couple is the lower trap, the upper trap, and the serratus anterior that work in concert to allow for those two force couples. The other force couple, or the other component of that, which we can't really model here, would be thoracic spine extension. That's another component that's working together to allow all of these motions to occur.
Tim, what about the levator and the rhomboids? I mean, they have a role on the medial border.
Sure. They're still going to help with elevating the scapula and holding that medial border against that as you go through those motions. They're certainly active as you elevate your arm and go through that to help stabilize the medial border and to elevate the arm as you're pulling with the levator. So with that superior component there.
It's very interesting that in that problem with the scapular muscle detachment, which is a problem with the rhomboids and low trap, you really cannot raise your arm very well.
So when the brain is asked to do a task, the body tries to compensate. So whether it's side bend or use what muscles are working, these are not as functional right now. So it shrugs and it elevates to compensate, to try to get your hand up to a kitchen counter or whatever you're trying to root. And then it happens 7,000 times over the course of the day, which puts a lot of stress in these.
That's exactly what we see in those scapular muscle attachments. It's that shrug, it's that medial border prominence that is the problem. Okay, Aaron, any other points here about the serratus? To me, the serratus is so very important. What do you think about that?
Well, it's just a bit an understanding, and I think this is what a lot of clinicians don't actually think about. Is we think of the serratus as this one giant muscle that does one thing, but the reality of it is we have fibers going in different directions. So the superior orientation of the upper fibers is more diagonal, going up around the thorax like so, which actually makes a ton of sense when we're talking about upward rotation as well as the external rotation functionality of this muscle. But then it's the inferior aspect that we really have to pay attention to because of the fact that it does attach to the inferior angle, And that's where we get a good portion of our posterior tilt. So understanding that downward orientation is critical as the arm reaches higher points of elevation, of pulling that inferior angle into the thorax to allow the rotation of the upper portion and the other muscles to do its job.
So Aaron, if you relax that lower, and I'm going to put my finger in here and then start to activate that, you can really see that sort of compress on my finger. And a lot of clinicians see scapular dyskinesis as that little inferior angle winging, and sometimes it's pathological. A lot of people just have that just because they don't have good activation. People do a lot of bench pressing or pressing activities, but they don't strengthen in overhead or upward rotation, which is where the lower fibers of the serratus have to be activated when the person gets up around 110, 120 overhead with resistance. So I think a lot of that is not so much inhibition, but maybe just detraining. And so when we combine that with the lower trap and your lower fibers, you get a nice flat area right here along the thoracic spine versus that inferior angle winging that we see a lot of times with mild scapular dyskinesis and sometimes in just normal people that have no pathology.
Yeah,
They worry about that.
Yeah, I think if you understand, there are actually 4 phases of scapular motion with arm elevation. This first phase occurs with the arm between 0 and 30 degrees of elevation, and that's when this setting takes place, that locking that inferior medial border down where it's supposed to be, which then allows everything else to work normally. If you don't have this setting position, just let that go loose. And you have that capability of doing whatever you want to. Now try to do your motions, and it'll kind of it kind of goes every which way. You have to have that locked in position in that first phase, or the other phases do not work as efficiently. And therefore, you're right, it's that mild dyskinesis, but it's the setup for these other things that won't necessarily happen well. So Jeff, in the thrower, we talk about how we always look at the glenohumeral joint, and we do all these exams and everything out here. Where does the scapula, where do these muscles play in getting ready for the thrower to throw?
Right. So first we got to get the arm overhead. So we've got to get that stabilization of the inferior medial border to get that arm overhead. And then we got to get the arm back and allow that external rotation of the arm. So we've got to get the external rotation of the scapula to allow the external rotation of the arm. Without that, we're getting internal impingement of the posterior labrum. What's fighting us a lot is a lot of pec minor. So that pec minor is pulling us inferiorly so that we're getting that internal rotation of the scapula and not allowing that external rotation of the humerus, is where we get into a lot of trouble with our throwers.
One thing is, I'm really bugged now on this clavicle business, but clavicle rotation is so very important. And so with the lower trap being an external rotator and a posterior rotator, that then allows this posterior rotation to occur, which then allows the acromion to get out of the way, which allows that position that we want to. So without scapular positioning, the arm cannot work at these high rotational speeds and high loads in a most efficient or anatomically stable way. So we get problems with the scapula not being in the right position, the deltoid, everything pulling. So you get all kinds of translations because of the arm movement off of an unstable scapula, which will give you those, we feel that internal impingement, which is a combination of scapular protraction and humeral posterior translation. So you get the protraction here and the horizontal adduction here, and all the load goes right back on the posterior labrum right there. As you rotate, you just grind that posterior labrum into pieces. So we feel that that's probably how the scapula needs to play a role. Now, Austin, you're the deltoid dude here. Now, we see these stress fractures of the acromion and of the acromial spine in reverse total shoulders. How do you think that plays out in this situation right here?
Well, what you see is you have a massive laterally directed force, and the weight of the arm is placing all that stress on the acromion. And so with abnormal mechanics, you're exacerbating that and really loading that lateral aspect of the acromion with attempted arm movement. Because the deltoid's the primary mover in a reverse total shoulder replacement, you're really placing that stress across that lateral acromion.
And if you don't have any of the medial border controls, then all the load is here and on the scapular spine. And therefore, you get the repetitive bending, which then leads to the stress. And that's exactly where the stress fractures occur.
Yeah, I
Right.
think that's a really good demonstration. When he's just pulling with his deltoid, if I activate my upper trap, I have no effect. But if we turn on Mr. Rhomboid over here and the lower trap, we
Now
start
it's
to
distributed.
we start to distribute that force a little bit more evenly. It's still a stress riser. That's just the mechanics of the surgery, as you would know better than I. But at the same time, if we're not working on these muscles early, because there is some limited external rotation, right? And so we have to focus on scapular retraction to get whatever limited external rotation we're going to get anyways for
The special low trap.
especially if there is no rotator cuff that's functional for you to fix. I know you fix what you can, but
Now-
there's only so much you can fix.
You two surgeons do total shoulder. How many patients would you estimate before you do a total shoulder have normal scapular kinematics?
Very little to none, because they've been compensating for years for not having a good rotator cuff. So they've learned different ways to elevate their arm, and that's usually coming through dyskinesis.
Now, Tim, as a motor control guy, removing pain from this situation and the glenohumeral joint, but by doing a total shoulder, does that automatically mean that the muscles remember how they're supposed to work?
No,
No, but see,
it
that's
certainly helps a lot.
yeah.
Pain is a big driver of muscle inhibition. It certainly helps a lot, but it's probably not quite as easy as like a total hip or a patient like that, where they're so much happy or after surgery, their pain is reduced, a lot more muscle fibers and strength of those muscles. But the arm is a more control-based segment, so we really have to retrain that. And hopefully, if they've gotten prehab, they've gotten some of that. But there is this whole process that we don't want to articulate any of the surgical repair and trying to avoid some of those motions. So there is a lot more rehab post total shoulder is suggested is needed.
There's a couple of papers that have come out that say that post total shoulder, there's a lot more activity in the upper trap. And does that make sense?
Yeah, I mean, that's their compensation they've been doing to lift their arm for the last 6 years or
All right.
however
So you got this going this way, and you got this going this way, and these muscles aren't working. So where are all the load going to go?
Yeah.
Right there. You got the bending moment between this, and all the bending moment is right there. If you don't control for the,
These are all loose and relaxed.
yeah.
But if we snug them up, it
Now you get
distributes
rid of
that
that.
force.
You neutralize that bending moment by working on the low trap. So we talk about a couple of patterns we see fairly frequently with this scapular dyskinesis, and of course we're looking through skin and muscle and everything else. But basically, we can say that there's this inferior medial border prominent, so the entire medial border is prominent, and you can see that either at rest or especially as the arm is coming down from this position. We call it the bounce or the jerk, where it comes out and it sticks out.
Mhm.
The other is inferior medial border prominence. We categorize that as type 1 in our first paper, and this medial border prominence is type 2 in our original paper. So I think we can demonstrate here what this looks like, and then we can go through why it is that way and what we can do intervention wise to make it better. So we'll put you want to do the type 1 or type 2?
let's do type 2 first.
Type 2, which is inferior medial border, entire medial border prominence.
The whole medial border is
So let everything go loose here just a second. So that is this position right here. Is that correct?
so just let it relax for a second and then have tight
Well, just-
pec, right?
So
Yeah,
and that takes
that would
here,
put
I'll-
it more
delta.
prominent.
So what we find that if it's deltoid or
The
arm
deltoids, they're trying to
arm
lift their
weight,
arm.
yeah, trying to raise the arm or down. And so what's going to cause it? So our pec minor is tight,
Mm-hmm.
and
Levator's tight.
the levator's tight.
Yep.
Okay, and what's loose?
Lower trap, middle trap,
And how about
Rhomboids.
and so
and serratus.
and straight. So how are we going to address that situation now?
Well, so usually what we try to do is get them in the right position before they lift their arm. So we're going to let you relax that arm a little bit.
So you got to have so you got to do, you can't do long lever arm,
Right.
and you have to get rid of your pec. Is
So
that
you have
right?
to minimize it.
Yeah.
So we're going to stretch.
Some
the
people
tight-
say get rid of it, but
Right. Yeah. Some people have the ability to cut tissue. Those of us don't. Athletic trainers and physical therapists work on mechanical stretching.
okay. All right.
So we would want to stretch the anterior muscles, but we have to simultaneously work on increasing the stability of the medial border and then turning on the serratus to really help correct that as he activates his deltoid to lift that guy up.
Well, what if are you going to try to minimize the deltoid load by having a short lever arm?
That would decrease the demand of the rotator cuff and the deltoid, so that would help with the pain and impingement type symptoms.
But at some point in time, you're still going to have a little bit of that. So you do deltoid close to the wall or something like
so
that. So
short lever arm or closed chain. When you put your hand on against the wall, you're lightening the weight of the arm.
Okay. So
Lightly.
so which order do you do this? Is the serratus more important? Is the low trap more important? What about the upper trap? Is the upper trap playing much? We always say the upper trap's tight in this situation too. Pull on that, Jeff. So it'll probably, will it cause some of that off to this? Yeah, it'll low, but it's mainly it's like the levator and the pec minor are the players.
So
tight.
so those tend to be more tight, or I don't know how much they're tight or they're just overused.
Okay, and then the rhomboids, which ought to be, they're not working at all there.
We are not at the moment.
So
We-
the
we have-
rhomboids are not working, the low trap's not working, and the serratus is not working.
So the rhomboids and the middle trap will work together to pull the scapula flush. The lower trap and serratus will help improve that rotation, especially if he pulls on those lower fibers. a little
Lower
bit.
fibers more than the upper fibers.
Lower fibers more than upper. Yeah. I mean, they both turn on. You're not going to be able to separate those.
Yeah, and
You can isolate the upper trap from the lower trap much better than you can isolate like components of the serratus. You sort of turn
Mhm.
all of the serratus fibers on.
So now are these specific? I mean, you're not going to try to say I'm going to strengthen the serratus anterior. You're talking about doing composite motions, composite interventions.
Exercises that bias one muscle group over another is the best we can probably do. We can't isolate
Yeah.
a serratus versus a upper fiber versus lower. We know EMG studies will show us certain activation patterns. Ian Cools has shown us that laying them on their side or laying them down can bias lower trap before they do upper trap with certain exercises. And we try to do that with the kinetic chain exercises, where we try to facilitate the trunk rotation and spine rotation to activate these more naturally as they tend to turn on and function.
So you got to get the tight muscles loose before you try to work on the inhibited.
Typically, it's best if you work on both, but you're going to start by stretching and then
Because you got to get rid of this tightness before you can ever make
we would
that
like
work.
to minimize that some, and muscles are plastic, so they change relatively quickly, not permanently, but they will change. So most therapists will go on mobility exercises first, doesn't aggravate them if they're pretty painful, and then light strengthening, and then more facilitatory activities as that tissue stretches. It's going to take a couple of treatment sessions to really get them trained up to be able to turn these on in a good sequence. But it's not like it's major strength gains. It's sequencing of the
Activation.
muscles as they do that. And some patients get it right away and some patients don't. And that's probably where the doctors have to sort of depend on the therapists and the athletic trainers and the occupational therapists to use that judgment to help facilitate that.
Speaking of doctors, Austin and Jeff, so you're in the room with a patient and you take their shirt off, or you can see the scapula and you see this thing sitting right here. Now you kind of get a better idea, I think, of what the problems are. This is rarely surgical. Sometimes you'll have a labral injury that'll do this way, or sometimes an AC joint or something like that. But what's your all's thought process now? If you see this medial border, how do you kind of evaluate for it? What do you do? Information to the patient and your instructions to the physical therapist. How do you take this patient with this problem right here and make them into this problem right here?
So for me, it's seeing where they're painful. Where are they having most of their soreness? Is it along the medial border? Is it which specific muscles are painful? Are they feeling tight along the pec minor? Are they painful along the pec minor? And then trying to go individually kind of through these muscles and systematically through these muscles and see which one's tight, which ones aren't activating, and where the sequence is going wrong. And trying to be very specific in that assessment so that I can communicate that well with the physical therapist. What do I think we need to address first? Is it the tightness, or is it the control? Is it the stabilization? And so trying to figure out which muscles are not turning on well, which muscles are tight, and trying to figure out how best to communicate that with the therapist.
Now, the patient can't see this. I mean, they can't see that. How do you communicate to them?
Oftentimes I'll use their cell phone. I'll take a video of it for them because sometimes folks can appreciate something just feels off. I just don't know where my shoulder is. It feels like my arm's heavy. It's just not feeling strong against my rib cage. Oftentimes they have no idea. So videotaping it so that they can see asymmetry back there, as well as we can kind of show them how that scapular motion is not providing their best outcome, their best strength with the arm away from their body.
And I think some tactile feedback terms like the scapular assistance test or the low row test, where you can engage some of their core in this. And I think that also provides them a lot of information, because they're seeing with mechanical stabilization that they don't hurt as much, or they can move better, combination of the two most commonly.
I get this from doctors a lot of times. I don't know what it is I'm seeing. Does this type of information help you all? Does it give you a little bit more tools in your toolbox? How do you feel when this patient comes in? You kind of do one of these, or do you feel like you can better address it if you understand what's going on here?
I think it's imperative that you start to see how the muscles function in order to understand. This is really complex motions we've seen, and by individually looking at these and then looking at them in concert, which is very difficult to conceptualize without seeing it in 3 dimensions, it's extraordinarily helpful.
And it's surprising how many patients will say, if you give them that scapular assist or give them that retraction, how much better they feel very quickly. If you just give them that little proprioception, they'll notice a dramatic difference. And so it's a good indicator of how well they can get with the right therapy.
Okay. Aaron, we talked about core. How does the core fit into this? The core is a really big part of this, and we feel like there's facilitation, especially of the serratus. So where does this all fit in?
Well, it certainly aligns very well with what we've talked about for a very long time about kinetic chain function. And when we're talking about the core being the central part of the body, obviously, and the fact that the larger muscles are located there and positioned there.
They're all attached.
Yeah, I mean, and the muscles being right there, secure to it. It makes really logical sense that whatever's going on in this part of the body is obviously going to affect what's further up the line, especially since most of what we do with our arm is a forward or overhead action. And so as a result of that, if we're having deficiencies here, we're going to have troubles further up the chain. And so when everything's optimized here, does it mean there's nothing wrong local? Not necessarily, but it certainly contributes in terms of overall function in that capacity, and to think of that manner. It's interesting the way we were just talking about it. It struck me, you mentioned tactile feedback on the examination, but we don't use a lot of tactile feedback in rehabilitation. We do a lot of open chain exercises. We don't, sit there with all of our patients and touch muscles necessarily for a long time, but yet we have literature that is showing that is very, very good for this part of the body now. And not just the tactile, but also verbal and visual feedback. And so, feedback's very key for the motor system. And since we can't see this part of the body, I think this ties in very, very well with maybe that's how we should start thinking about rehabilitating this part.
Tim, we talk about all these muscles, and we say the muscles aren't working, and we say that it's not necessarily weakness, like, 3 out of 5 muscle strength, but it's more of an activation. Is that correct? I mean, is there an inhibition, or we see some of these patients who, as Jeff said, they have no idea how to place voluntarily their scapula in this position. Where does that come from? It appears in my clinical experience that if you have about 6 or 8 weeks of pain or dysfunction of the shoulder blade, this will be there. If it's less than that, then they can do it, but they lose something. What is this something that they're losing, and how do you test for it, and how can you kind of, I think a tactile is important, but tell us a little bit about the difference between weakness and lack of activation.
Proprioception,
Yeah.
motor control, neuromuscular control, and proprioception. You were feeding into my dissertation. So we know that so a long time ago in an animal model, they rolled ankle ligaments in cats, and that's where the concept came out of, that you had a deaffernated ligamentous system. We certainly know about that in ACLs and ankle sprains. We don't typically tear a ligament in the shoulder. Obviously, you can dislocate and have some of these symptoms, but that's probably not the main thing that we see. So it's not a ligament proprioception, but it's the spindles in the muscle fibers, the Golgi tendon organs. And I do think pain drives a lot of this. I think there is some natural, people are not maybe as strong in their core as they should be. Not everybody does what Dr. Stone wants them to do, 100 of repetitions of core every day. But the same concept is that you still get proprioception from muscle, and skin is another component. So we can use that as therapists and athletic trainers to try to facilitate that motion. So I think it is pain drives the symptom. It gets inflamed, it gets irritated, there's a trauma or there's overuse. And then over time, that changes the way we move. And so we have lost that pattern of movement control that is normal or is beneficial. And we overuse our upper traps, or we overuse our other tissues, and that we've now changed the movement patterns. I always tell my patients, it only takes you a step or two when I put a rock in your shoe to change your gait pattern. And so this has been going on for 6 months or 6 years or however long. It's going to take a little while to retrain that motor pattern. And it's not as simple as taking the rock out of the shoe. You guys take the rocks out of the shoe when you fix tissues, but then it's up to us to move them, help them move those muscles and fibers. So I think a lot of it is re-educating them how to move. And I think your idea of using video, we have mirrors here in the clinic all over, and Aaron's done a really nice job using mirror feedback. There's a whole concept of somebody to move their hand using a mirror box to teach them to get over that initial fear of movement and trying to facilitate that retraining of motion. So what works on Billy Bob is not going to work on Jane. And so we have to sort of figure out what it is for those folks. And you have to have a very broad thought process as you go through this.
Unfortunately, in a referral practice, we will see a lot of patients who have had PT. And when I evaluate them and I say, well, you got this deficiency, you need a PT, and they'll roll, I've done PT. And so I've always said, well, we're going to show you some exercises that you've probably never done before, but this is the reason for it. And so one of the ways that Jeff, that the test we do to kind of show them that they don't know where the shoulder blade goes, how do you do that test?
And so essentially, to look at the motor control of the shoulder blade, we put their good arm on a wall. So that we're kind of resting the arm comfortably, and we ask them to set their shoulder blade, retract their shoulder blade. Can they get into a good position? Then we'll do it on the inhibited arm, the pathologic arm, have them set their arm on the wall, try to set their shoulder blade, and you'll notice they often have a very hard time setting it. The other thing too is ask them to step away from the ball. Can they maintain it with the weight of the arm as well? And so oftentimes that dyskinesis, they just have a very hard time finding the normal scapular retraction position, and it's very evident very quickly.
And so and therefore you have to understand that there are these other exercises, like we said, the short lever arm, the closed chain, starting with the hip and core, getting rid of all the tightness. they'll come in there and they'll be doing this, and they'll have such tight pec minor that you can't even get them back sometimes. And so all this has to play into the education of the clinician, of the evaluator, as well as the patient, so that everybody's on the same page, so that this very variable possibility, there's a zillion different positions the scapula can take in three-dimensional space, depending on the compensations, on the loads, on the motions, things like that. So you really have to, so it takes some time. It's not like a 5-minute, let's look at your x-ray type thing. So how long, we talked on our original video, we talked about the comprehensive evaluation of the scapula. But I think it really takes maybe 10 minutes, 15 minutes to really go over this in a systematic way, like you're talking about. Any other little pearls that we can talk about understanding the scapula a little bit more?
Well, I think that the thing we do need to mention, though, and it's something because of the way that we as the rehab people are taught in school on the eval side of things, is that we spend a lot of time very early on focusing on strength testing individual muscles. And the reality of it is that as the science has gotten further down the line over the years, we realized that that probably isn't as accurate as we thought it once was. We all spend much time learning all these numerous
The
tests,
muscles attach.
where they attach, and let's put the arm in certain positions and resist it. And if it can't be resisted, then okay, that's a weakness. But the truth of the matter is, since we know we're not stopping other muscles from working, and we cannot in any way, shape, or form say that one muscle is definitely the problem, which then ties into our treatment side. How do you treat one muscle? As Tim alluded earlier, you can't really do that. And so I think we need to shy away from thinking that way. It was a good first step, but as I said, the science expanded, and we're probably not where we once were with that thought process.
If there's one muscle here that's not working, is that really the case?
No, just one is not.
Yeah, let's say
inhibited.
yeah, let's say that one muscle's, I mean, can you really say that one muscle not working is going to affect this whole thing either for good or bad?
Probably not.
Not the
I mean,
best
there-
example is that serratus anterior palsy, where you can't raise your arm any higher than this.
Right. There's a lot of weakness with a long thoracic nerve palsy that they really can't function, even though the axillary nerve is fine,
Every other muscle in the body is normal except for the serratus, and yet you can't raise your arm. But
or push, or
yeah, so that's probably the worst case scenario. But in all these other situations we're talking about, it takes multiple muscles either being too tight or not working well, activating weakness, inhibition, whatever, to make this happen. And so we have to understand that when we see this right here, it's not only what's going on here, it's what's going on here as well.
Mhm.
That makes that symptomatic. Let's put it that way. So say what? So tell. So what's
So,
what's
this is a typical presentation of like a type 1 dyskinesis that might present in an office. And what we've tried to do is simulate that with tight muscles and activation. So they're trying to lift their arm. So we have the deltoid working. We have tight pecs.
so
we
the
have-
pec minor's tight.
Pec minor's tight. The upper trap and levator are trying to lift that arm up, but this inferior angle is sort of prominent because maybe these other muscles aren't working as
Which other muscles are not working?
so the lower trap, or I'm sorry, the lower fibers of the serratus. So if you start to pull on the lower fibers of serratus, good, and then relax again, Aaron. That starts to bring that type 1 down to where we want it. And then if we combine that with the lower trap and the lower fiber,
And let this pec minor.
and let that there we go. There's the rotation. Oh,
There-
nice.
there's-
Let's do that again. Very good, gentlemen. Great teamwork.
So
there you
everybody
go.
see that. So if you get rid of the pec minor tightness,
So if we did therapy, right, we would we would ease off. It's not going to ease off that much. You wish, Kevin.
I can cut it. Make it
I know you are. We don't have those skills. And then so going to make it tight again. So relax your lower fibers there, Aaron. Good. All right. So that's where it starts. So it starts there is tight. So we're going to lighten the pec minor, and then we're going to start to activate the lower trap and the lower fibers of the serratus to reduce that type 1 component. And that's probably how I would actually start rehab. Stretch the pec, start to get the lower fibers or the lower trap fibers. And then because that really turns on when you lift your arm, I have to bring that in sort of secondary to the strengthening component so that I don't get too much upper trap
How
activation.
about the levator? I mean, the middle trap and the rhomboids.
Yeah. Well,
Are they going to?
well, the middle trap helps stabilize. This stabilizes, but it actually causes more downward rotation.
Yeah, so we don't want to emphasize that.
I tend to want to overemphasize the lower trap
Okay.
and not the rhomboids.
Yeah.
So if you do rows, right? Everybody
Mm-hmm.
likes to do pulling exercises. It's push day or pull day. And so on pull days, you really can't separate these two muscles.
Uh-huh.
They don't isolate very well.
Uh-huh.
There's been studies out of Mayo Clinic and other folks that have looked at, we can't even manual muscle test them differently. So they're almost always going to work together. And that's going to feed into that downward rotation, which will tend to make this more prominent or put more stress on that. So if we don't have the lower trap,
rows are not. You don't want to work rows too much. But how you do your serratus and low trap then?
well, you have to teach the patient to turn on those muscles. It's not just pure strength. It is actually turning on the lower trap and then bringing in the lower fibers of the serratus to get this back flush.
Okay, so now tighten up the pec again. So in the presence of the pec tightness, how effective will your low trap and serratus exercises be?
Minimal.
Yeah, so that shows the importance of the pec minor. First of all, to identify it, and second of all, to make sure that it is not a player.
Or minimize its tight.
Yeah.
Or cut it if you're a doctor.
And
That's
you know, also to Tim's point, the number one go-to when we start to think scapula, people believe it's these large, massive motions, and when we're talking serratus, we think push-up. We think push-up plus.
Good point.
Right. And so if we're trying to correct this altered motion and we don't want such,
Do a
this-
push-up plus here.
Exactly. Right. And so, I mean, if we're combating mobility, then unfortunately, then this is not really helping the situation. Let's be realistic. And so it's just a different line of thought.
Push day, pull day.
Exactly.
Push day, pull day.
Right.
So
It's not strength. Is we got to do this sequentially and for the reasons that we're doing it, which is correct the order of the activation.
order of activation and turning off. Sometimes turning on a muscle is not as hard as turning off a muscle.
Unfortunately.
So trying to get somebody not to turn on their upper trap or levator as much is more challenging than doing that. So biofeedback and I think that's where a lot of people have started using more soft tissue releases, dry needling, acupressure, trigger point injections, because that really helps shut off or at least momentarily shut off some of those really tight muscles. So there's certainly a place for that in the treatment algorithm. Okay. So what do you want to do?
So is the inferior medial border. This is
So
we
this
see
is a type 2
type 2.
pattern.
And once again, we notice that it's a lot of this eccentric load, long lever arm load, that creates the situation. If you don't have that, then you don't have it. See, there's the problem right
So
there.
when they go to lift, every time they lift their arm,
Yeah,
their deltoid is on.
deltoid's on. You have a long lever arm, and that puts all that load on that, and and that's where you get. And so bring it back down. There it goes. You see, so up, and then back down. See, there's the board. There's the medial border right there.
So you
see?
get that medial border prominence
I
without
think that's a great example. See, so we're up, and then we're
duck in the.
and then we're down.
There you go.
See the medial border, and that's what we see clinically on the way down. We see that medial border prominence.
So we're going to lighten the deltoid ward by shortening the lever arm. We're going to stretch the pec. So we're going to take some of that tension off. We're going to stretch the upper traps and levator a little bit so things start to settle. And then we want to re-emphasize lower trap, middle trap as they lift, and serratus. So that border stays flat.
Yeah.
That was a little.
So now as we bring it down, now tighten up your muscles like you wanted to, and
Okay.
we'll bring it up again,
So now you see
and bring it back down.
it stays flush on the thoracic spine.
On the rib cage,
Or-
yeah, on the rib cage.
Sorry, rib
Yeah.
cage. It stays flush to the ribs
Yeah.
as it goes around. Go on and pull that up again, guys. Good. And then
Yeah, see how that just keeps that right on there. And in rehabilitation, you would lower the load here.
right,
with
just
short
by
lever arm,
shortening the lever arm,
closed chain.
closed chain, keep the hand against the wall, so this doesn't have as much work to do. You still have to engage the deltoid or your arm's not going to go up.
Mhm.
That's for sure.
And eventually you're going to want to be able to do this out here, but that's
Right. That's
lower later down the road.
as these get
That's
more strong or more
activated.
activated, these get a little looser, then things start to balance back out.
And to think too that obviously we don't have everything represented on the model, but one of the things obviously we see quite a bit that we have to address is latissimus tightness.
Absolutely.
And so as the arm is in this positioning,
Is that
and
that is what we're missing, that sort of
Well,
pulls it down.
that's kind of substituted by this right here, which is what it does.
right. And so what we ultimately end up seeing then that is a contributor to this anteriorly tilted, internally rotated position is that latissimus pulls down on the humerus. And now it's something we need to consider as part of our rehabilitation.
Yeah.
And I think that's one of the things that people cheat with, right? So if you're trying to retract your scapula and you say pull it down and back, the down comes from the lat, not from these muscles.
Mhm.
And so they tend to overactivate that. You can inhibit that by keeping the arm elevated
Mhm.
until they learn to do that. They can't, you'll feel that lat turn on. And if you can get their arm in a comfortable position overhead, obviously there's still a lot of irritation of the rotator cuff, that they don't love it when you get above 60 degrees because of the impingement that's occurring, or the subacromial space is really minimal and it's around 50, 60 degrees. And so we have to respect that. And
Mhm.
so initially in rehab, we're sort of somewhat limited in how we can activate that. I think that's why facilitating it with the trunk or other techniques is really nice to be able to do that, where we're not pulling that
Mhm.
lat so hard.
One final point, I just have to make it, is that we're talking about the scapula, but remember, this is the claviscapula. This segmented unit works together. It has the AC ligaments and the CC ligaments that make this work as a unit. So anything that destroys or alters the function of this unit right here, whether it be AC separation, distal clavicle excision, or CC ligament injury, or clavicle fracture with anterior rotation of the distal fragment, will alter the kinematics in a way that the muscles cannot necessarily compensate for. Because this becomes what I call a hard dyskinesis, because now you've got these other things that the muscles cannot work well, cannot overcome the loss of the anatomic capability. So remember, when you're evaluating these patients, that AC joint is stable, the CC ligaments are intact or repaired, and then if you have a clavicle fracture, that there's no component of anterior rotation, which you see everything that attaches here will tend with a clavicle fracture to pull this piece that way. So you really are altering the normal curve and the normal position and normal capability of posterior rotation of the clavicle if you do not adequately anatomically restore this unit right here. It has implications for what type of surgery you do, when you do surgery, etc. Remember that if this is bad, then your canary in the coal mine is what's going on with the scapula in the resting position. If it's anteriorly tilted, droop, then you can see it on your scapular exam. As you can see, this model can be used in several ways. The first, of course, is to demonstrate the normal scapular motion and the normal muscle activities that create that normal scapular motion as the arm is elevated and depressed. In addition, it certainly can show patterns of clinical dyskinesis. It'll show the positions of the scapula and also the muscle activations, either not enough activation or too much activation, that create the clinical dyskinesis. And that way we can actually develop interventions that can help restore the normal kinematics. So hopefully what this will do is allow us to have a much more complete understanding of this very complex motion and put some kind of parameters around what makes the different types of dyskinesis present and what we can do to alleviate them and to restore this back to normal. So I think it'll be really good help for these purposes. Future videos will actually use the model in interventions and show some of the exercises specifically that will be used to help the restoration of the normal scapular kinematics.